From beautiful Sydney, the city of Opera House, Darling Harbour, Blue Mountains, and beautiful beaches, this is ICU Primary Prepcast, a monthly podcast about physiology and pharmacology in intensive care.
Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And this is our last episode before the Christmas. And Maddie, obviously this is a festive season. So how's your preparations and what's your plans?
I don't know yet. I have to work on Christmas, unfortunately, but usually spending some time with the family. We just moved house. So now I think we'll try and get a Christmas tree and decorate it. But otherwise, this year's just flown by. I can't believe it's almost Christmas.
I know. Especially the 2020. Everybody's kind of so looking forward to 2021. Especially now the borders are open. People can travel within Australia. I think everybody's looking forward to these celebrations around that Christmas, New Year period. So I hope all the listeners enjoy their festive season. And obviously this festive season will bring joy and a lot of positivity for 2021. So without delaying much time, let's dive into our today's episode, which is the respiratory physiology. Now, we kept this topic towards the end of this podcast series deliberately because it's kind of complex topic, but also the syllabus is quite vast. So Maddie, let's start with the basic anatomy. So can you please describe the anatomy of trachea and bronchial tree to the level of the segmental bronchi?
The trachea is a fibrocartilaginous tube, which typically has an inner diameter of about 2.5 centimeters and a length of between 10 to 16 centimeters. It begins at the lowest border of the larynx, which is around the level of C6, and ends by bifurcating into the right and the left main bronchi around the level of T5 to T7. So the trachea itself is a D-shaped in cross-section and consists of curved cartilage rings anteriorly and a flat longitudinal muscle called the trachealis posteriorly. The top of the trachea contains the cricoid cartilage, which is the only complete ring of cartilage in the trachea. Extending downward throughout the length of the trachea are between 15 to 20 C-shaped cartilaginous rings, which are composed mainly of collagen. The trachealis muscle joins the end of these rings, and the esophagus lies posteriorly. The trachea is supplied by the inferior thyroid and the bronchial arteries and innervated by the vagus nerve and T2 to T6 sympathetic chain. It is lined with pseudostratified columnar ciliated epithelium and goblet cells which produce mucus. The cilia and the mucus form the mucociliary escalator, which traps inhaled foreign particles and sweep these substances up to the pharynx, where they can either be swallowed into the stomach or coughed out. The bronchial tree consists of 23 divisions, the first 16 of which are the conducting zones, as they do not participate in gas exchange, and the remaining 7 divisions comprising the respiratory zone. The bronchi have a similar structure to the trachea, except that the main bronchi have cartilage rings that completely encircle the lumen, while the lobar and the segmental bronchi have incomplete rings of cartilage. The blood supply to the bronchi are via bronchial arteries, and the venous drainage is via the hemizygous and the zygous veins. The first division of the bronchial tree is the right and left main bronchus. At this bifurcation, there is a ridge of cartilage called the carina, which runs anteroposteriorly. The right main bronchus is about 2.5 centimeters long and wider and more vertical compared to the left. The esophagus vein arches over the right main bronchus from behind it. The right pulmonary artery initially lies below the right main bronchi and then later anteriorly to it. The right main bronchus has 3 subdivisions known as secondary or lobar bronchi. The first is the right upper lobe bronchus, which arises from the superolateral wall and branches into segmental or tertiary bronchi, which are the apical, anterior, and posterior bronchi. The right bronchus intermedius runs distal to the right upper lobe bifurcation and divides into the right middle and right lower lobe bronchi. The right middle lobe bronchus transverses the right hilum into the right middle lobe and divides into branches to the medial and lateral segments. The right lower lobe bronchus arises as a continuation of the bronchus intermedius. It divides immediately into an apical segmental bronchus and 4 basal segments, which are the medial, lateral, anterior, and posterior segments. The left main bronchus is about 5 centimeters long and passes inferiorly to the arch of the aorta and anteriorly to the thoracic aorta and esophagus. The lobar branches are the left upper lobe and left lower lobe branches. The left upper lobe bronchus divides into the superior division and the lingular division. The superior division gives rise to the segmental apico-posterior and anterior bronchi, while the lingular bronchus divides into the superior and inferior bronchi. The left lower lobe bronchus divides into bronchi to the apical, anterior basal, lateral basal, and posterior basal segments.
Thanks, Maddie. When this question came for the first time in the primary written exam, a lot of candidates struggled to answer this question. And even for the fellowship exam, I think a lot of candidates still struggle to explain the bronchial anatomy. Especially if you're going to perform the bronchoscopy in ICU, I think knowledge of anatomy is must. So I guess this question should be very straightforward. And also with this question, if you can draw a neat labeled diagram, that will be a bonus. Now, let's go further. And there's another important component of the respiratory system, and which is obviously one of the most important muscles for inspiration, that is diaphragm. So can you please outline the anatomy of the diaphragm and its function in respiration?
The diaphragm is a large membranous dome-shaped skeletal muscle which separates the chest cavity from the abdominal cavity. It is the most important muscle for inspiration and has motor innervation by C3 to 5 by the phrenic nerve. The sensory innervation of the peripheries of the diaphragm is by the 6th to the 11th intercostal nerves. And the blood supply is by the subcostal and the lowest 5 intercostal arteries and the inferior and superior phrenic arteries. The diaphragm is comprised of peripheral muscle which insert into a central tendon that ascends to fuse with the inferior surface of the pericardium. On either side of the pericardium is the right and the left domes of the diaphragm, the right one lying slightly higher due to the liver. The peripheral muscle of the diaphragm originates from 3 areas: the sternal part, the costal part, and the lumbar part. The sternal part originates from the posterior aspect of the xiphoid process, while the costal part arises from the internal surfaces of the lower costal cartilages and ribs from 7 to 12. The lumbar part originates from the medial and the lateral arcuate ligaments, the bodies of the vertebra from L1 to 3, and the anterior longitudinal ligament. The parts that arise from the vertebra are tendinous and known as the right crew, which arises from L1 to 3, and their intervertebral discs, and the left crew, which arises from L1 to 2, and their intervertebral discs. Some of the fibers from the right crew surround the esophageal opening and act as a physiological sphincter. The diaphragm has 3 major openings through which structures can pass from the chest to the abdomen. These are the caval hiatus, the esophageal hiatus, and the aortic hiatus. The caval hiatus is at T8, through which the IVC and the terminal branches of the right phrenic nerve pass. The esophageal hiatus is at the level of T10, through which the esophagus, right and left vagus nerves, and the esophageal branches of the left gastric artery and vein pass. And the aortic hiatus is at the level of T12, through which the aorta, thoracic duct, and the zygous vein pass. The diaphragm contracts during inspiration, which causes it to flatten, resulting in an increased volume of the thoracic cavity. This decreases intrapulmonary pressure and helps air to flow into the lungs. During normal breathing, the diaphragm can descend about 1.5 centimeters, but with forced inspiration, it can descend by up to 10 centimeters. This descent of the diaphragm also increases intra-abdominal pressure, and the combination of raised intra-abdominal pressure and reduced intrathoracic pressure helps to increase venous return to the heart. When the diaphragm relaxes, the intrathoracic volume decreases, intrapulmonary pressure increases, and this aids in expiration. Furthermore, diaphragm contraction assists in the contraction of muscles of the anterior abdominal wall to raise intra-abdominal pressure during processes such as vomiting, defecation, and childbirth.
Thanks, Maddie. So again, one of the most important muscles of inspiration. Let's dive into another component of the respiratory system, that is the vascular supply of the lungs. So can you please briefly compare the pulmonary and bronchial artery?
The The lung has a dual blood supply comprised of the pulmonary and the bronchial arteries. The pulmonary arteries are a low-pressure elastic system with much thinner walls compared to the systemic arteries. They carry deoxygenated blood from the right ventricle to be oxygenated in the lungs. They supply 99% of blood flow to the lungs and participate in gas exchange at the alveolar capillary membrane. The bronchial arteries carry only about 1% of total cardiac output and carry high-pressure oxygenated blood to the supporting structures of the lung, including the conducting airways down to the level of the terminal bronchioles, the nerves, lymph nodes, visceral pleura, and the walls of the large pulmonary vessels. They do not participate in gas exchange. The pulmonary arteries have pressures of about 25 on 8 millimeters of mercury, while the bronchial arteries have systemic blood pressures, so approximately 120 on 80 millimeters of mercury. The bronchial arteries arise between T3 to T8, and there are usually 2 left and 1 right, but sometimes there are also additional smaller bronchial arteries arising from the descending thoracic aorta. The left bronchial artery arises directly from the anteromedial thoracic aorta. The superior left bronchial artery arises near the level of the aortic arch, lateral to the carina and posterior to the left main bronchus. The inferior left bronchial artery arises from the aorta parallel to the superior artery, but inferior to the left main bronchus. The right bronchial artery has a common origin with a posterior intercostal artery and arises from the right anteromedial aspect of the thoracic aorta. The pulmonary trunk arises from the base of the right ventricle, passes behind the ascending aorta, and splits into the left and right pulmonary arteries at the level of T5 to T6. The pulmonary trunk is covered by pericardium and lies with the ascending aorta. It contains a pulmonary valve which allows blood to flow from the right ventricle to the pulmonary trunk. The cusp of the valve form mild dilatations called sinuses. The left pulmonary artery is a direct continuation of the pulmonary trunk and is shorter than the right. It arches over the left main bronchus before reaching the left lung. The right pulmonary artery arises at about a 90-degree angle off the pulmonary trunk and runs underneath the aortic arch, then behind the SVC to the right lung.
Thanks, Maddie. Let's dive into the respiratory mechanics now. So can you define lung compliance?
Lung compliance is the change in lung volume per unit change in transmural pressure gradient. So that is the pressure difference between the alveolus and the pleural space. It is normally expressed in mils per centimetre of water. Lung compliance can be described as static or dynamic. Static compliance is the change in volume divided by a change in pressure, measured in the absence of gas flow. Therefore, it is not affected by resistance. Dynamic lung compliance is the compliance during respiration or in the presence of gas flow. It is always lower than static compliance as it incorporates resistance to airflow. Specific compliance is a compliance normalized for lung volume, which is calculated by taking static lung compliance and dividing this by the functional residual capacity. This allows us to compare the compliance of lungs of different volumes, and a normal value is about 0.05 mils per centimetre of water.
And what are the factors that affect lung compliance?
So there are several factors that affect lung compliance. These include the presence of surfactant, lung volume, posture, pulmonary blood volume, airway resistance, airflow, and lung elastic recoil. Surfactant is one of the primary factors that affect lung compliance, as this decreases the surface tension at the alveolar air-water interface and prevents small alveoli from collapsing. This increases lung compliance. Lung volume is another factor. The compliance is greatest around the functional residual capacity and reduced at high and low lung volumes. Decreased lung volumes, such as with collapse, consolidation, or lung resection, will decrease lung compliance. But this can be negated by calculating the specific compliance. Posture also affects lung compliance. Lung compliance is highest in an upright position, lower in a supine position, and lowest in a lateral position. Prone positioning can result in an increased lung compliance compared to supine position. Pulmonary blood volume also affects compliance, with pulmonary venous congestion decreasing lung compliance. Airway resistance can also affect lung compliance, as increased airway resistance decreases the dynamic lung compliance. Increased airflow, such as with increased respiratory rates, also decreases this dynamic lung compliance. And finally, lung elastic recoil can affect lung compliance. Decreased elastic recoil, such as with emphysema, causes increased lung compliance, while increased elastic recoil, such as in pulmonary fibrosis, results in decreased lung compliance.
That's right. So again, lung compliance is extremely important phenomena for any ICU trainees to understand, especially when you are setting your ventilator in the ICU for your patient. And one of the ways to kind of look at lung compliance of the patient on ventilator is to look at your P peak pressures and P plateau pressures. Obviously, the P plateau is more important than the P peak because, again, that's kind of indicates your static lung compliance. And if your P plateau, usually the traditional cutoff is less than 30 centimeter of water. And if that is not the case, and obviously patient has a significant problem with the lung compliance, and you need to adjust your setting, and lung protective strategy needs to be considered in ventilating this patient. So it's very important to know how to measure lung compliance on ventilator for your patients in ICU, and what are the factors that affect lung compliance. As you mentioned, sometimes the resistance can affect lung compliance, but usually when you ventilate patients with asthma, which is purely a resistance problem, usually the lung compliance is still pretty good. Now, that's a kind of nice segue into the last question of the podcast is airway resistance. So what are the factors that affect airway resistance?
Resistance is the change in pressure divided by flow, and the normal airway resistance is 0.5 to 2 centimeters of water per litre per second. The main determinants of airway resistance are the size of the airway and the properties of gas flow. So we can firstly think of this in terms of rearranging the Hagen-Purcell equation, where resistance then equals 8 times viscosity times length divided by pi times radius to the power of 4. Caveats to this is that the Hagen-Purcell equation is reliant on laminar flow, which is not always the case within the airways. But thinking about this, the determinants of airway resistance are the airway radius, the nature of gas flow, the composition of the gas, and finally lung volume and location. Firstly, airway radius has a major effect on the resistance to airflow. A reduction in radius size will increase the resistance by a factor of 4. Changes in airway radius can be due to changes in bronchial smooth muscle, such as increased tone with bronchospasm and decreased tone with bronchodilators. Decreases within the intraluminal area of the airway, such as in the case of edema or secretions, and mechanical obstruction or compression, such as extrinsic compression by a tumour. Secondly, the nature of gas flow can affect airway resistance. This is defined by Reynolds number, which is equal to the diameter times velocity times gas density, all divided by the viscosity of the gas. Less than 2,000 is generally laminar flow, 2,000 to 4,000 is transitional, and greater than 4,000 is usually turbulent flow. Laminar flow involves an orderly, concentric distribution of air particles which moves through a tube in parallel layers, the central of which flow with the greatest velocity. Laminar flow has low resistance and is constant, and flow is proportional to the driving pressure. Turbulent flow refers to air flowing in a disorganized, chaotic manner at different speeds and pressures. Turbulent flow is proportional to the square root of the driving pressure. Therefore, to double the flow, the pressure across the airway must be quadrupled. Turbulent flow occurs when the air is at high velocity in larger diameter airways and when the density of the gas is increased. Airway resistance increases exponentially when flow is turbulent. The next factor that can affect airway resistance is the composition of gas. Decreased gas density decreases airway resistance as per Reynolds number. This is why helium, as it is less dense than oxygen, may reduce airway resistance by increasing the likelihood of laminar flow. The second factor is viscosity. Increased viscosity will increase resistance as per the Hagen-Purcell's law, but also decreases Reynolds number, therefore increasing the likelihood of laminar flow. In practice, gas viscosity is relatively less important as the viscosity of gas does not vary much, and the density is more important for airway resistance. Finally, lung volume and location can affect airway resistance. Lung expansion causes the airways to also expand and will decrease airway resistance. Resistance is usually maximal in medium-sized airways and actually low in smaller airways, as airflow occurs in series within these smaller airways.
That's right. And I think that's also important to understand that concept of equal pressure point, especially when you're ventilating the patients with COPD versus patient with asthma, because in asthma, we ventilate almost sometimes with a 0 PEEP, because the equal pressure point is already towards the carina or towards the proximal airways, while in COPD patients, the narrowing or the compression is towards the distal airways. And that's why we can use some PEEP to bring the equal pressure point towards the carina. And that's why sometimes if you see emphysema patients, they breathe via pursed lip breathing to generate that auto PEEP. So again, just simplified physiological applications of this concept. Now, this is our last episode of 2020, and this is a pre-Christmas episode. And I was praying to Santa that Maddie might give me a gift of pardon from her dad jokes. Maddie, is that true?
No, because it's a present for the rest of the listeners.
Of course. Somebody's pain is somebody's joy.
That's right.
So sure, we should continue this tradition even going in 2021, because I think people love your jokes. So yeah, let's continue.
So why is breathing more effortless during a hailstorm?
Maddie, we just had a hailstorm a few weeks ago in Sydney. Because it's simple, isn't it? Like everything is pretty bad in hail. So yeah, breathing gets difficult in hail, I guess.
No, it's just easier to inhale.
Oh, come on. Oh my gosh.
That's a good one.
This is a good one. But I was close this time. I think I'm getting better overall. So thanks, folks. So that's the end of our today's episode. Once again, wish you a Merry Christmas and Happy New Year in advance. Hopefully this festive season brings you joy, prosperity, and a very positive attitude towards 2021. And all your unfulfilled dreams in 2020 will get fulfilled in 2021. So wish you all the best.
Thanks for listening, everyone. We'll see you next time.